A well-functioning relationship with surgeon and anesthesiologist is the most critical element for safe and high-quality perioperative care. When the conflict between two groups is unresolved regarding decision-making, there comes our rescuer, the cardiologist. Our next talk is about cardiac evaluation and surgical emergencies and bridging anticoagulants. I consider it is a great honor to welcome Dr. S. Murugan Sir, Dr. A.P. Yuvaraj Sir, and Dr. P. Vijay Sir on the stage to moderate this session. Dr. S. Murugan Sir did his MBBS from Thanjavur Medical College and MD General Medicine from Stanley Medical College and MD Cardiology from Madras Medical College. He is the Managing Director and Consultant Interventional Cardiologist in Erode Medical Center. Dr. Yuvaraj Sir is a consultant physician. He did MBBS and MD General Medicine from Annamalai University. He is a Managing Director of Dharani Hospital, Chennai. Dr. P. Vijay Sir was graduated from Madurai Medical College and post-graduated in General Medicine from Madras Medical College. He did DNB Cardiology from Southern Railway Hospital, Perambur, presently working as a consultant interventional cardiologist in Care 24 Hospitals, Erode. We welcome you all, sir. May I invite Dr. S. Murugan Sir to introduce and welcome our passionate speaker, Dr. N. Rajasekar Sir.
Good morning to all. We are moving on to an interesting session. I welcome Dr. Rajasekar, Consultant Interventional Cardiologist to the hospital, to deliver his lecture without wasting much time.
Good morning, respected chairpersons, respected doctors. So today we are going to discuss how to evaluate the heart and how to manage the heart pre-operatively and during surgery and post-surgery. So before going to the discussion, we should know what is the definition of surgeries based on timing. That is, what is emergency surgery, what is urgent surgery, what is time-sensitive surgery, what is elective surgery. This is how we will classify surgeries. So emergency surgery is surgery which has to be done at the earliest. There is no time to evaluate. We should do immediately. Otherwise, we are going to lose the patient. We are going to lose either in some organ or limb. So during emergency surgery, majority of the time, no need of much evaluation. But whereas in other type of surgery, that is urgent surgery, time-sensitive surgery, we have little more time to evaluate. Whereas elective surgery, there is no need to have so much rush. We can. So whatever I am going to discuss is based on the recent recommendations and guideline by European Society of Cardiology that is published 6 months back, and it was also endorsed by European Society of Anesthesiology and Intensive Care. So we have 4 different categories of surgeries. What I am going to discuss is about the first 3 categories, that is emergency surgery, urgent surgery, time-sensitive surgery. So for these 2 categories, surgery must be done at the earliest to save life, limb or organ. So for emergency surgery, there should not be any delay. We have to do the surgery within 1 to 6 hours. Whereas urgent surgery, we can try to evaluate and we have time up to for 24 hours. Time-sensitive surgery is like example is cancer surgery. We cannot postpone the surgery, but at the same time, we have to evaluate and try to give time for heart and everything. So there is a risk of losing limb and organ function if you are delaying too much, and there is increased complication, reduced outcome for the surgery. So you have to perform as soon as possible. Maximum time we have is 1 to 6 weeks. So with this, we'll go to the epidemiology of our current problem. So we have around 31 crores of surgeries happening every year, and we can see that around 42 lakh death per year is because of surgery. It is the significance is it's the 3rd greatest contributor to death actually, next only to stroke and heart disease. It is 3rd greatest contributor, especially in Europe. So of all the deaths, 50% is cardiovascular death, and unfortunately, majority of the time, cardiologists are not directly involved in these managing these patients. So our aim is to pick up early and treat early so that we can reduce the cardiovascular disease and cardiovascular complications. So by cardiovascular complications, why cardiovascular complications happen during surgery? For whom it will happen? Majority of the time, even for asymptomatic coronary artery disease, we must try to evaluate properly, and patients who have reduced CF and patients who are going to undergo a prolonged surgery because of hemodynamic and cardiac stress, there are a lot of reasons heart will get damaged. Heart, I mean, it's myocardium. So there is other problems like valvular disease and arrhythmic disease, but here our main concern is to preserve and protect the myocardium. So why myocardial damage happened during surgery? Again, there are plenty of reasons. One of the main reasons is hemodynamic fluctuation because of lot of fluid loss, blood loss, a lot of IV fluids, and anesthesia causing autonomic dysfunction, and bleeding during surgery can activate the platelets and activate the clotting factor, which can cause thrombosis, and stress can increase the hormones like corticosteroids and adrenaline, which can cause vasoconstriction and plaque rupture, which can cause acute coronary syndrome. And of course, interruption of antiplatelet, if it is unsupervised, can also cause acute coronary syndrome. So how to evaluate myocardial damage and how to protect the heart before surgery? We routinely do this. There is no doubt ECG echoes nowadays, it's a dictum for any surgery. We are routinely doing this. But is it enough? So we have another important parameter that is called exercise capacity, which is a must. Easy to ask the patient. If a patient is able to climb 2 flights of stairs, the patient is definitely fit for surgery, and there is a less chance of developing cardiac complication. But is it still enough? So we have one of our case, patient presented with diabetic, well-controlled diabetic, developed a neck of femur fracture. ECG echo was done, which was normal. Surgery was done successfully. Surgeon were happy, anesthetists were happy. But unfortunately, the next day, patient suddenly developed breathing difficulty. Everything will happen suddenly. Patient was shifted to ICU. Showed the ECG showed anterior MI. So, what we call this? There is no one to blame. Surgeon was excellent surgeon. Surgery went successfully. Anesthetists were excellent anesthetists. There is no problem during surgery. So what happened during, how to prevent such a scenario? So what we call this term as perioperative myocardial injury. So not all patients will develop myocardial infarction like this patient. So majority of the patients will develop myocardial injury. So this term is called PMI. So there are plenty of reasons for PMI, and the classical coronary artery disease causing PM is very rare. That is around only 7 to 10% of the patient only have the classical typical myocardial infarction. Majority of the patient will have atypical presentation and atypical causes like anemia, hypoxia, hypotension, tachyarrhythmia, stress cardiomyopathy, sepsis, acute kidney injury. These are the causes which can cause myocardial damage. So rather than saying it as perioperative myocardial infarction, the term is perioperative myocardial injury is the actual terminology we use in such patients. So we can see that when we see the epidemiology of PMI, the typical type 1 MI, that is atherosclerotic MI, is only 7%. Majority of the time, 73% is type 2 MI, that is demand-supply mismatch causing myocardial infarction. Is majority of the time, that is the reason for myocardial injury. So, as I said, most of the time, 90%, as per all the studies, 90% of the time it is asymptomatic. This is because of many reasons. One is because of anesthesia, there may not be pain, and because of surgical reasons, surgical scar pain, the patient may deviate, and we may also deviate from the actual symptom. Patient may have nausea or drainage, whatever the reason. And also cardiologists are not seeing the patient directly. That is also another reason we may miss early. So these are the reasons for asymptomatic. Although patients are asymptomatic, it doesn't mean that it's benign. The mortality is almost equal to symptomatic myocardial infarction. So mortality associated with asymptomatic PA is found to be comparable to that of symptomatic myocardial infarction. So again, coming to investigations, is it enough? Actually, ECG echo was done in that patient. Still, patient developed myocardial injury. How to prevent such things? So that is why ESC recently came with troponin. So troponin is a known test we do routinely, but not in surgery patients. So is it a must now? So troponin I mean high sensitive troponin T or high sensitive troponin I, not just a CART test. So this is a recent guideline which shows that it is a class 1 indication. Even echo is not mentioned here. ECG and biomarker is a class 1 indication for preoperative assessment in patients who are undergoing surgery. So for whom we have to do troponin T and troponin I, whether all patients who are undergoing surgery has to be, do troponin T. In 3 scenarios, we must do troponin T. One is any patient age more than 65 years. Any patient age is more than 65 years, troponin T is a must. And those who are at risk of cardiovascular disease, even if age is less than 65, more than 40 years, patients are diabetic, uncontrolled diabetic, having other coronary artery disease, or cerebrovascular disease, peripheral artery disease, or microvascular complication of diabetes, anything at risk of cardiovascular disease, or those with already cardiovascular disease, all these patients must undergo troponin T or troponin I. And whether all surgeries require troponin T or troponin I. So in this patient, he is a 66-year-old, troponin T would have been very useful in this patient. And what type of surgery, whether all surgeries require troponin T or I, the answer is intermediate and high-risk surgery. Cardiologists would have mentioned during surgery fitness that patient is having low cardiac risk, patient is having intermediate cardiac risk, patient is having high cardiac risk. What do we mean actually by that? High cardiac risk is if patient is having a chance of developing cardiovascular disease is around 5%, more than 5%, we mention it as high cardiac risk. Intermediate cardiac risk is the chance of developing cardiovascular disease during surgery or next 30 days of surgery is 1 to 5%. That is intermediate cardiac risk. Low cardiac risk is if it is less than 1%. So these are high surgical risk patients. That is adrenal resection, major vascular surgeries, carotid surgeries, duodenal pancreatic surgery, liver resection, bile duct surgery, esophageal surgeries, and lower limb surgeries, pneumonectomy, lung and liver transplant, bowel repair, and total cystectomy. These are high surgical risk candidates. Whereas intermediate surgical risk are other cardiovascular surgeries, head and neck surgeries, intraperitoneal surgeries, and non-major intrathoracic and neurological surgeries, and renal transplant, and major gynecological and urological. These are all intermediate and high surgical risk. For all these surgeries, we must do high sensitive troponin T. So when to do? So this patient who presented with us, he was normal and he developed MI. When to do, what is the time we have to do troponin T? So this is a nice chart. So before any surgery, ECG and troponin T is a must. And after 1 day of surgery and after 2 days of surgery, we have to repeat the troponin T. So these are all must. And we have to see the serial differences. If any difference is there, we should call it as PMI. And we have to start evaluating for PMI by clinical assessment, do ECG, do echo, find out what is the reason for PMI, check the blood, whether anemia is there, rule out sepsis, rule out pulmonary embolism, do echo and find out if there is a stress cardiomyopathy there. ECG will show MI. So try to manage the reason for PMI. So this is a class 1 indication I told, troponin T before intermediate or high risk patient, before surgery and at 24 hours and after 48 hours. It's a class 1 indication now. And this is a second patient who came to us 2 months back. He is a 65-year-old. He was managed conservatively for gallstones. Unfortunately, he now presented with acute cholecystitis. He is a classical cardiac patient. He had anteroalami 3 years back, undergone angioplasty also for that. His EF was low, EF was 30%. Because of altered bowel habits secondary to gallstone, he tried to strain during stools and developed dyspnea. So when he presented with pulmonary edema and also acute cholecystitis. Now he is having very high cardiac risk for surgery. So what to do in such scenarios? So here another biomarker is very useful here. That is NT-proBNP. This is also important biomarker we can do. Here the patient had NT-proBNP of around 12,000. So we treated him with IV diuretics, dyspnea resolved, patient became asymptomatic except for GI symptoms. So NT-proBNP was normalized. Then we took for surgery. We kept him in ICU for 2 days for observation. He was stable and then discharged. So again, NT-proBNP is also a important biomarker which we can use during surgery and after surgery. So coming to bridging anticoagulant and antiplatelet, this I am going to discuss for both emergency surgery as well as elective surgery. By bridging antiplatelet, I mean that not all, by the way, bridging, it doesn't mean that we have to bridge only with heparin. There are other bridging therapies like bridging IV antiplatelets, that is tirofiban. That is also very important to know. So this is another patient who came to us 2 months back. He had undergone primary angioplasty for anterolami 2 months back, and he had an unexplained weight loss for which we evaluated. We found out he had a renal cell carcinoma. So he needs nephrectomy. He was on dual antiplatelet therapy. So what to do in such situation? So he has recent MI and he needs time-sensitive surgery, that is nephrectomy, because he is having cancer. So for this, we need to ask 3 questions. Whether risk of acute coronary syndrome is there if antiplatelet is stopped, or is there any risk of high bleeding during surgery, and can we postpone the surgery? If we are able to answer these 3 questions, we can easily decide what algorithm he belongs to. So this is a very important chart which shows when to stop antiplatelet. Many doctors will say, many anesthetists, many people will say that 6 months recent guidelines is saying we can stop antiplatelet beyond 6 months. Not like that. It also depends on many other factors. So more than 12 months, it is very easy to stop antiplatelet. I mean clopidogrel, we can continue aspirin. If it is a simple angioplasty, patient was not having any acute coronary syndrome, it is very safe to stop antiplatelet beyond 6 months of initial acute coronary syndrome, even initial PCA event. Whereas if the patient is having a complex angioplasty or patient undergone a myocardial infarction, it is safe to stop after 12 months of therapy. And we should never stop within first 3 months of acute coronary syndrome or complex angioplasty, and we should never stop within first month of even simple angioplasty. So there are many factors which we will determine during whether to stop antiplatelet or not, like whether patient has undergone complex angioplasty like left main intervention or CTO intervention or bifurcation intervention, how many stents have been deployed, what is the diameter of the stent which has been deployed, and what is the LVEF of the patient, what is the renal status, what is the diabetic status of the patient, whether he had a stent thrombosis in the past, whether he had a clopidogrel resistant type of patient. So all these things we consider in mind before trying to stop dual antiplatelet therapy. It is not a single yes or no question. So if the patient is having high risk of bleeding, assess whether there is high risk of thrombosis also. If there is no high risk of thrombosis, if there is no high risk of bleeding during surgery, we can safe to continue with both antiplatelet. There is no question of stopping antiplatelet. The question arises, what are the causes of high bleeding risk surgeries? So these are minor bleeding risk, no need to bother. These are low bleeding risk. These categories, no need to bother about continuing antiplatelet. It is very safe to continue both antiplatelet and also safe to do the surgery. There won't be much bleeding risk. Whereas only these high bleeding risk category require stopping antiplatelet. That is abdominal surgery with liver biopsy, even other abdominal surgery like cholecystectomy, hernia repair, colon resection, all comes in low bleeding risk category. Whereas high-end abdominal surgery, so like liver biopsy, extensive cancer surgery, or any even spinal or epidural anesthesia is a high bleeding risk category. And neurosurgeries like intracranial and spinal surgery, major orthopedic surgery, and vascular surgeries, and colon polypectomy, and thoracic surgeries, and majority of urological surgeries and vascular surgeries belong to high bleeding risk surgeries. So for these categories, we must try to stop antiplatelet if surgeon is requesting and anesthetists are requesting. So if the patient is having high bleeding risk, we have to think whether patient is having high thrombotic risk also. If there is high thrombotic risk, high bleeding risk, then we have to do a bridging IV antiplatelet. If there is risk of high bleeding, then we have to assess whether there is low thrombotic risk or high thrombotic risk. If there is high thrombotic risk, Whether we can able to postpone the surgery is a question. If there is it's not possible to postpone the surgery like cancer surgery, we must try to bridge with IV antiplatelet. If there is a low thrombotic risk, then we can safely stop one antiplatelet and continue aspirin. So stopping antiplatelet, ticagrelor for 3 to 5 days, clopidogrel for 5 days. If prasugrel, it is for 7 days. If we want to bridge for antiplatelet, the bridge is not with anticoagulant, that is not with heparin, but with GP inhibitor or cangrelor, that is tirofibin or cangrelor. These are the agents we must use if we are going to stop clopidogrel, ticagrelor or prasugrel. So again, for this patient, 3 questions: whether there is any cardiac risk if antiplatelet stopped. Of course, only 2 months after MI, definitely there is a risk of cardiac problem. There is high bleeding risk because of nephrectomy, renal cell carcinoma, and it is not possible to postpone the surgery. So what we can do is stop clopidogrel 5 days before surgery and start on tirofibin 3 days before surgery. Continue tirofibin infusion 6 hours till before 6 hours before surgery. Take the patient and discuss with the surgeon and the team and start antiplatelet from then onwards. So when to restart antiplatelet, try to start within 48 hours. So oral anticoagulants, we have discussed about oral antiplatelet, few slides about oral anticoagulants, how to bridge. So no need to remember the big chart. We can see here, these 3 things is enough to remember. Bridging is not recommended, bridging is not recommended, bridging is not recommended. So majority of the time for oral anticoagulant, bridging is not recommended. We can stop the oral anticoagulant, proceed for surgery. Only in 2 scenarios we require bridging. One is if the patient had a mechanical heart valve. Another, if the patient is having a very high thromboembolic risk. There are only few scenarios. Patient recently treated pulmonary embolism, patient is having LV apical clot, or patient is having a recurrent atrial fibrillation, who are having a high CHA2DS2-VASc risk score. Only in these 3 scenarios, we have to bridge with anticoagulants. So majority of the time, we can escape from bridging. So do a short interruption. This will be very useful for Novax, that is apixaban, dabigatran, divarasib. Now it is renamed as Dovax. So it is these 2 are BD dosage, this is OD dosage. That is important to know. If it is a BD dosage, if minor bleeding risk, just stopping 12 hours is enough. If it is a OD dosage, 24 hours stopping is enough. So this is a simple chart showing if the patient is having high bleeding risk during surgery, if it is a Novac, stop for 2 days before surgery, stop for 2 days after surgery and restart it. No need to bridge in between, unless the scenarios I told. So with this, so let me summarize. First, we have to classify the patient profile, whether patient belongs to emergency surgery, urgent, time-sensitive or elective surgery, and whether patient belong to low, intermediate or high cardiac risk, and whether surgery is a high bleeding, low bleeding or minor bleeding, and whether there is high thrombotic risk or low thrombotic risk if we are going to stop the antiplatelet. And this is a recent emphasis. Biomarker is a must in all intermediate and high cardiac risk patient if patient age is more than 65, having cardiovascular disease or is a known cardiovascular disease patient. And bridge with IV antiplatelet, not with IV anticoagulant if we are going to stop antiplatelet and if bridging is necessary. No bridging is needed in majority of patients on Novac and majority of patients in acetram and warfarin. So bridging heparin may be needed in selected patients on warfarin and acetram, especially if patient on mechanical heart valve, for which we never use Novax, we only use warfarin and acetram. So with this, I will conclude my slides. Thank you.
It was indeed a great presentation, sir. I think it has enabled us to understand the strategies very well. Thank you very much.
Thank you.
The most deadly thing truly is when our heart fails. We have an enthusiastic speaker to pump you up and love your heart. I'm delighted to invite Dr. A.P. Yuvraj sir to introduce and welcome the second speaker of this session, Dr. Shanmugasundaram sir.
I would like to invite next speaker, Dr. Shanmugasundaram sir, who is a very eminent speaker. Right now, he is working as senior consultant cardiologist in GKNM Hospitals, Coimbatore. His field of interest is heart failure and echocardiography. He earned a gold medal in his MD General Medicine in MMC. He was trained in advanced heart failure and transplantation in Papworth Hospitals, Cambridge, UK. He had contributed a lot to textbooks and he had more than 15 publications in national and international journals.
Good morning, all of you. Let me thank the organizers for giving me an opportunity to be a part of this program. So I'll just go through some of the cases with acute heart failure we came across in our medical ICU as well as cardiac ICU. Throughout my presentation, I'll try to stress the importance of point of care echo in various case scenarios. Like as you know, like the point of care ultrasound has become standard of care in managing any medical ICU. So in the same way, the echo also coming up, the cardiac focus or echo focus, where the utility of echo in diagnosing, evaluating as well as strategizing the management is coming up. So with some of the case scenarios what we came across, I'll just try to stress the importance of the point of care echo. So to start with, this was 80-year-old male, a diabetic and hypertensive, who came with a history of chest pain for a day and increase for the past 4 hours. He came with ongoing chest pain and breathlessness for a few hours. On clinical examination, his BP was stable. He was tachycardic and tachypneic at rest with minimal desaturation. Heart sounds were normal with short systolic murmur with bilateral basal crepitations. ECG showed features of acute inferior wall myocardial infarction. So this was the X-ray. As you see, like you can see the cardiac shadow was fairly normal. There's no significant cardiomegaly, but fluffy opacities on both the sides suggesting pulmonary edema, which correlates with the clinical picture as well. So this was his echo. For those who are familiar, this might be easy to interpret. For those who don't, I'll just briefly go through. This was the parasternal long axis view, which shows like LV is not really dilated. The anteroseptal wall is contracting well. The infralateral wall is akinetic, which in fact coincided with the ECG finding. And this is a short axis picture, which shows the inferior and infralateral wall is fairly akinetic. You see, this is the fourth chamber where this is the left ventricle and this is the left atria. The LV is not dilated. LV systolic function is fairly preserved. So, like with such a preserved LV function, why should he have pulmonary edema? Obviously, he had a clue by clinical examination where there was a systolic murmur in the apex. So, this again shows that significant mitral regurgitation. This is the mitral valve and the left ventricle and left atria here. You can see that significant mitral regurgitation, and which is again shown in the pansystolic jet, which is recorded by the spectral Doppler. So this was an acute inferior wall MI with significant or severe mitral regurgitation, which is the reason for his pulmonary edema. So he was loaded with antiplatelets, statins, low molecular weight heparin, and obviously because of the pulmonary congestion, he was started on IV diuretics with nasal O2 and non-invasive ventilation. We in fact offered coronary angiogram and revascularization because of his clinical presentation. He denied. That does denied because of his age, and they weren't financially ready. He was thrombolized with tenecteplase. Subsequently, because of his mitral regurgitation, he had worsening breathlessness. We tried to manage with intravenous diuretics, but he had persistent congestion. So, like, since he wasn't really willing for invasive management, we had to go for subsequent intense medical management. We started with intravenous sodium nitroprusside, that's the lowest possible dose to begin with, and we uptitrated gradually. The pulmonary congestion subsequently gradually settled, and we could see there was improvement in the cardiac output, worsening, the worsened renal function started improving. Subsequently, he was started on oral vasodilators, and we tapered sodium nitroprusside. Then again, like he wasn't really willing for invasive management, so he was just kept on oral vasodilators and antiplatelets along with statin, which he tolerated subsequently. Now he has basically class 2 breathlessness, which is manageable medically. So moving to the second case, this is again 80-year-old lady, diabetic and hypertensive on regular drugs, presented to the emergency with breathlessness of recent onset, a weak duration, and with a recent worsening, class 3 for the past 2 days, and minimal swelling of the legs. Heart rate and BP was normal. She was not tachypneic or desaturated. Clinical examination was fairly unremarkable. She was initially evaluated in ER. This was her ECG, except a bit of low voltage in limb leads and non-specific ECG changes in chest leads. She didn't have much of ECG changes. And X-ray again, like there was minimal bilateral pleural effusion and apparent cardiomegaly, probably because of AP view, and some increased bronchoscopic markings in the right side. She was initially seen in ER. She was just, in fact, they did troponin that was negative and NT-proBNP was normal. She was just managed symptomatically with IV diuretics and asked to come to the cardiology OPD subsequently. On the next day, she came again with persistent symptoms. Her BP was 110/80. Her previous record showed that BP was in fact slightly in the higher side. It was 140/150 systolic. So when compared to her baseline, this was in fact low and JVP was mildly elevated. This was her echo. It is quite obvious to see that this is the parasternal long axis view again. Shows echo free space, that is fluid collection anterior to RV and posterior to LV. The same was seen in the short axis view as well. There is almost a circumferential fluid, so moderate to large pericardial effusion, as it is seen in apical fourth chamber as well as subcostal. Can you just see the slide? Screen, please. So she in fact had a large pericardial effusion with clinical evidence of tamponade as evidenced by the presence of pulsus paradoxus and relatively hypotensive. Yeah, now it is. Yeah. So like she was, in fact, she also had the features of tamponade. I'm not going through the details of echocardiographic evidence of tamponade. So she had large effusion with tamponade. She underwent urgent pericardiocentesis, which showed hemorrhagic fluid, exudative collection. No obvious reason, because I mean AFB was negative, gram stain was negative. Yeah, though ADA was slightly higher, we couldn't really demonstrate tuberculosis. And subsequently, CT again didn't really reveal the exact etiology. So we presume that probable viral pericarditis without any obvious evidence of malignancy. She was under follow-up for 6 months with no further reaccumulation. So the point I would like to stress here is, like, had we done a probable echocardiography in ER itself, we could have picked up this earlier. We could have planned for pericardiocentesis on the previous day itself. So like, as I told you, like the point of care echo is really essential in ER or any intensive medical care unit for earlier diagnosis of these kind of illnesses, so that we can avoid catastrophe. I'll just go through the third case. It was a 48-year-old lady, not a known diabetic. She is hypertensive, breathlessness for the past 4 days. She had a history of long travel a week back, and she also had swelling of the left calf for the past 3 days. Obviously, you would have guessed the diagnosis. She was a bit hypotensive, 90/60, and tachycardic, mild tachypnea with minimal desaturation. So this was her ECG, sinus tachycardia with right bundle branch black pattern with probable RV strain. So X-ray, no much of clue. Mild cardiomegaly, otherwise pulmonary vascular markings are fine, no pleural effusion. So blood investigation in emergency showed elevated D-dimer, HS tropi was elevated, otherwise it was unremarkable. So this was the echo bedside, which again showed, this is the parasternal long axis view, this is the left ventricle, dilated right ventricle, which is evidenced in the parasternal short axis as well. The septum is flat, interventricular septum is flat. The septum is pushed, in fact, towards the left ventricle. This is the dilated right ventricle. It's quite obvious by the apical fourth chamber as well. This is the left ventricle and left atria here. This is the right atria which is dilated and right ventricle is dilated. So this is the color flow across the tricuspid valve, shows significant tricuspid regurgitation. So this was the tricuspid regurgitation velocity. It was mildly elevated and IVC is dilated. In fact, having a pulmonary embolism, which is hemodynamically significant in the background, we just gave unfractionated heparin 5,000 units, and she was planned for CT pulmonary angiogram for confirmation of the diagnosis. Unfortunately, she had hemodynamic compromise even before being shifted for CT. So, since she had hypotension, we started her on vasopressors and judicious use of fluids. We couldn't really shift her for CTPA itself. So we just did a bedside venous Doppler which showed left leg proximal deep vein thrombosis. So with the background of long travel, left lower limb DVT with the dilated RAR, we obviously diagnosis almost certain that it is going to be a pulmonary embolism. We lysed her with tenecteplase. Her hemodynamics improved in an hour. So subsequently, she was managed with low molecular weight heparin and newer anticoagulants. We did a CT just for confirmation after fast stabilization of hemodynamics, which showed the thrombus on either side, which is partially resolved in the right side and near completely occluded still in the left side. But subsequently, the hemodynamics improved with anticoagulants. See now the size of the right ventricle, which was dilated earlier, now it started coming down, and it's fairly close to normal. Again, in short axis, this is the left ventricle and this is the right, which was dilated much in the earlier, now it has started getting better. So this is the 4th chamber view again, shows that which was dilated RARV earlier, now started coming down. So the point again I would like to stress here is, like, we can in fact thrombolize or diagnose pulmonary embolism fairly confidently with a clinical background. And if we have, or if we could document deep vein thrombosis bedside itself, so if the patient has significant hemodynamic compromise, we can go for a definitive management with thrombolysis, even with echocardiography and subsequent other clinical supportive findings. So this is the case 4. This was a 70-year-old lady, a known diabetic, which was poor control, and she in fact was admitted with diabetic foot elsewhere. She in fact had to undergo a repeated wound debridement because of large diabetic foot. She in fact had a prolonged hospital stay, almost 20-25 days of hospital stay there, with repeated surgical procedures, debridement. She had breathlessness for last 2 days in the hospital stay, in the outside hospital, and she was diagnosed to have probable acute coronary syndrome. She was referred to us for further management of acute coronary syndrome. With non-invasive ventilation and injection noradrenaline for hemodynamic support. This was the ECG at admission. As you could see, there was almost poor R wave V1 to V4 with T inversion in anterior chest leads with leftward axis deviation. This was the echo on the bedside. As you could see, the basal segments are contracting mid and apical segments are fairly akinetic in the apical 4-chamber view. This was the left ventricle. This is the apical 2-chamber view. Again, fairly similar finding. The basal segments are contracting with mid and distal segments are either akinetic or even ballooning out. And the same finding was noted in the apical long axis view. No significant mitral or aortic regurgitation. So there was significant LV systolic dysfunction with wall motion abnormality noted in mid and apical segments with severe LV systolic dysfunction. X-ray shows some evidence of pulmonary congestion with mild cardiomegaly. This was the initial parameters. Her tropi, the lab value standard, upper limit of normal was 45. This was elevated. But what we could see is for the amount of LV dysfunction and ECG change what she had, probably not really a proportionate elevation of tropi. That was a suspicion to begin with. But obviously, any such ECG and echo, we need to obviously think of acute coronary syndrome with anterior MI as a first diagnosis. But we did have another suspicion of stress cardiomyopathy since she never had chest pain, and trop again was really proportionate to the quantum of ST as well as echo changes. So we just had this in the back of our mind. We admitted and managed her with dual antiplatelets, statin, LMWH. We had continued parenteral inotropes because of the hemodynamic compromise, along with heparin. But on the next day, this was early morning, this was the ECG. There was significant ST elevation in anterior chest leads. ST could be noted, lead 1, 2, AVL, almost all the leads showed ST elevation. Then, obviously, we don't have a choice now. We had to rush her for a coronary angiogram and to look at the coronary anatomy and revascularization if needed. We did take her to the lab. Unfortunately, I couldn't load the angiogram. Angiogram showed no significant lesion in LAD except mid LAD showed 20-30% in the LAD and diagonal showed 60 to 70%. There was TIMI 3 flow, which really could not explain the quantum of ECG change or LV dysfunction what she had. So then, it was a tough decision at that point of time, whether to think about stenting diagonal, whether to do something for the LAD, for the ST what she had, but with a large wound infection in the background, and obviously things were not really fitting in with the acute coronary syndrome at that point of time. We just chose to manage conservatively, but this was the next day ECG. Very alarming and really worsening ST change. We could hold our hands back without rushing her to cath lab again. We thought we'll just manage her conservatively. But subsequently, we could really taper inotropes, start on vasodilators, start slowly beta blockers. Her hemodynamics started settling subsequently. ECG started settling subsequently without any revascularization. This was day 3, day 4 ECGs. We could see there was improvement in the ST segment. This was the last ECG what she had. We could no further angina or breathlessness, tachy reduced, inotropes tapered and stopped, NAV weaned and stopped, and she was managed with other routine ACS measures, regular wound dressing. Limb wound remained unhealed even after VAC dressing. So she was planned for below-knee amputation because of large lower area and uncontrolled infection there. So we thought we'll repeat one echo. So almost all the wall motions totally subsided. LV is normal. That was almost over day 7, day 8 of the hospital stay. So retrospectively, what we thought was we were in fact probably dealing with a stress cardiomyopathy, though there were significant STT changes, which was not really explained by the coronary anatomy what she had. So it could very well be a stress cardiomyopathy, though we cannot 100% say no for anterior with recanalized LAD. So what I would like to stress is I don't want you to take home, the take home message is not that ST elevation, we need to think of stress cardiomyopathy. Obviously in 99.9% of the cases, it is just still a STEMI. ACS has to be thought of, but stress cardiomyopathy has to be kept in the back of our mind in patients who are presenting in any medical ICU or surgical ICU with unexplained hypotension, unexplained tachycardia, like when patients who are post-operative, patients who are getting admitted with poisoning, patients who are getting after any stressful surgery like amputation or anything. This has to be kept in mind, which is most of the time it is self-limiting. Only thing is we need to be really careful with the inotropic dosage. We need to be using inotropes as less as possible because of the pathophysiology is inotropic toxicity, which is the reason behind stress cardiomyopathy. So because of the time, I'll just skip the 5th case. I'll just go to the take-home message part of it. That was again interesting one, but yeah. So what I would like to stress is the echo focus or cardiac focus, point of care ultrasound. Echo as a point of care tool, it is really important. It is really useful in many of the situations where in medical as well as cardiac ICU, hemodynamic instability, hypovolemia, what is IVC status, are we going to give fluids or not, are we going to give vasodilators, are we going to give inotropes. It is really useful. It will really help us troubleshooting. We can, those who are presenting with breathlessness, chest pain, hypotension, it is really handy. We, in fact, need not really go for a detailed echo looking at all the parameters. We can just look at a visual assessment of LV, visual assessment of LV systolic function. You look at the size of RV compared to that of LV, look at the aorta, look at the IVC. So just a visual assessment, when we tune our eyes to a normal size, we can obviously easily diagnose the abnormalities, what we can notice. So to conclude, cardiac focus, it is a useful addition for emergency decision making in medical, surgical ICU and cardiac ICU. It will really help us to see whether do we really need inotropes, do we really need vasopressors. We can choose agents depending upon the echo finding. And choice of vasodilators and inotropes matters. It is not just a blanket statement of either noradrenaline helps for the majority or dopamine helps for the majority. Obviously, echo really will help us in troubleshooting. Thank you.
Thank you, sir, for your informative presentation. We rarely get this kind of opportunity. Thank you very much.
I hope everyone knows that feeling when you meet someone and your heart skips a beat. Yeah, that's arrhythmia. You can either be in chaos or die from that. But we have a renowned speaker to bring your heart to a normal rhythm. I now request Dr. P. Vijay sir to introduce and welcome the last speaker of this part, Dr. P. Ramprakash sir.
It's my pleasure to invite Dr. Ramprakash sir, electrophysiologist and consultant cardiologist in GKNM Hospital, Coimbatore. He is an expert in radiofrequency ablation, pacemaker implantation and implantation of for advanced heart failure. He is a great teacher and highly dedicated person. No one is better than you, sir, to give us talk on arrhythmia.
So thank you, everybody. So we will go to the use of ECG in the ICU. So ECG is a window for the electrical activity of the heart. So apart from arrhythmias, there are so many other things that ECG can give us an information on. So it can give information on the cardiac status, like cardiac arrhythmias, ischemia, and other conditions, and also the medical status of the patient, like drug overdosage, poisoning, so how it is affecting the patient. So there are a few slides on that also that I will present now. So coming to arrhythmias in the ICU. So we will deal with the unstable arrhythmias that we are going to see when you are in the ICU. So what is an unstable arrhythmia? Any arrhythmia that causes hemodynamic compromise or has the ability to cause hemodynamic compromise if not treated promptly and correctly. So this is an unstable arrhythmia. It is either already caused a hemodynamic compromise or it has the potential to cause a hemodynamic compromise. So it can cause sudden cardiac arrest, syncope, hypotension, altered sensorium or pulmonary edema or congestion. So all these things are an indication that the arrhythmia is hemodynamically compromising the patient and it needs a prompt diagnosis and an accurate treatment for that arrhythmia. It has to be terminated immediately or it has to be corrected immediately. So these are potentially life-threatening situations. As ICU care physicians, you will be seeing it day in and day out, and this is one of the most challenging things in in critical care, because you have very little time for making a strategic decision and then treating the patient correctly. So this is a cardiac arrest is one of the things you have to find out what kind of cardiac arrest it is, whether it is asystole, bradyarrhythmia or tachyarrhythmia. And then you have to take an immediate action, plan a management and execute it effectively, swiftly, so that the patient is kept alive. So various causes and mechanisms you need to know, and the measures to be taken as an emergency. So what we see is it can either be treated acutely, either with medication. Some of them are self-limiting, some of them needs to be treated with medication or electrical therapy, or some of them the cause has to be treated primarily to get rid of the arrhythmia, like ischemia producing polymorphic VT. It is not important to not only treat the arrhythmia, but you have to treat the ischemia. Like primary arrhythmia or ventricular fibrillation in myocardial infarction, you have to first treat the arrhythmia and then also effectively take care of the coronaries. And like torsades de pointes, you have to first treat the torsades and then effectively treat the electrolyte imbalance that is causing it. Like any poisoning, digitalis poisoning causing heart block, you have to first pace the patient and then treat the poisoning that is causing the arrhythmia. So for an important rule for every critical care physician is, so for hemodynamically unstable tachyarrhythmic patients, the precise diagnosis of the ECG patient for specific treatment of the type of arrhythmia that is present is less important. So patient is collapsing, he is having a wide QRS tachycardia. There is no point in debating whether it is a SVT with aberrancy or a VT. All you have to do is, you should know there is a wide QRS tachycardia, the patient is hemodynamically unstable, and cardiovert him. Give an electrical shock, give a defibrillator. So that is more important. So that is what it really simplifies the treatment protocol. But further management, how do you manage him later on, is very much dependent upon the accurate diagnosis of the arrhythmia. But for an emergency, there are few things that has to be in your mind as a reflex action. And rapid institution of effective treatment according to the criteria that are as simple as possible and easy to recognize even under time pressure. So coming to the same example of SVT versus VT, so there is a Brugada's algorithm that has some 7 steps. So any algorithm that has more than one step will not help you in an emergency. It may help you in the exam, it may help you with a discussion with the colleagues, but not in an emergency. So first thing is, when you see a wide QRS complex tachycardia, you will see whether it is hemodynamically stable or unstable. It is unstable, cardiovert. So you have to devise or have these simple strategies to manage patients with arrhythmias in the ICU. So I will show a few slides on the common arrhythmias that you may be seeing in the ICUs. So bradyarrhythmia needs a immediate resuscitation. So bradyarrhythmia and concomitant administration of atropine, catecholamines until temporary pacemaker stimulation is available. So very easy to identify bradyarrhythmias. The patient will have a heart rate of less than 50, and the patient will be hemodynamically unstable, altered sensorium, pulmonary edema. All these things are an indicator of instability in these patients, or the patient may have a total cardiac arrest. So in this situation, it is immediately necessary to treat the patient with either atropine or an inotrope, catecholamines like adrenaline or isoprene, and then go on with the specific treatment like temporary pacemaker insertion. So every ICU physician should know how to insert a temporary pacemaker on the bedside. So acute myocardial infarction with second degree AV block, Mobitz type 2 block, 2:1 AV block, higher degrees of AV block, high grade AV block, complete AV block, or bifascicular block are an indications for temporary pacing in the ICU. So, sometimes it can be used as a bridge or a degenerative complete heart block. Patient with presenting with recurrent SA attacks, Stokes-Adams attacks or syncope is an indication for a temporary pacemaker, so that the rhythm can be kept stable until a permanent pacemaker is being implanted. So bradyarrhythmia is caused by intoxication. One very important intoxication is yellow oleander. So yellow oleander, day in and day out as critical care physicians you will be seeing. So this is very, very handy. So you can do a temporary pacemaker till the effect of the drug washes out or the oleander poisoning washes out. Acute emergencies with asystole or atropine resistant symptomatic bradycardia of unknown cause. So always you may not be able to pick up the cause for this bradyarrhythmia. Even then, do not break your head to know the etiology of the bradyarrhythmia. First put in a temporary pacemaker, which can either be transvenous pacing, or you can at least have an epicardial pacing, and then discuss and decide on the cause of the arrhythmia, whether it is reversible or not, and so on and so forth. So this, I'll show a few slides of bradyarrhythmias that can occur with syncope. So this is a typical 6 sinus syndrome. So initial part there is atrial fibrillation. So and then suddenly the atrial fibrillation terminates and the sinus node does not pick up and there is a long pause. So this pause can produce a syncope or cardiac arrest, or sometimes unless there is a escape rhythm that occurs after the atrial fibrillation terminates. So initially there is a junctional escape followed by a stable sinus rhythm escape. So this again was a very interesting case that we had. The patient with old inferior wall MI presented to the OPD with throat pain, sore throat. So he was sent to the ENT OPD, and after a few minutes we had a code blue from the ENT OPD. So guess what happened? So the ENT surgeon, he examined the neck for any palpable nodes or this thing. So while palpating the neck, the patient had a carotid sinus hypersensitivity and collapsed in the OPD. And then we took him to the cath lab, did the same carotid sinus massage with a temporary pacemaker inside. So as soon as we touched the carotid sinus area, there was a long inhibitory pause, that is cardio inhibitory response because of the vagal stimulation produced by carotid sinus massage. And of course, we had a pacemaker in situ. We started pacing the patient. So this is one more thing we can. The other thing is second degree AV block. So whenever there is group beating, bradycardia with few impulses occurring together and there is a pause. Few impulses occurring together, there is a pause. You have to always suspect a second degree AV block. Tachycardia with group beating is ectopics. Whereas a bradycardia with few impulses occurring together with a pause is very likely to be a second degree AV block. So which is of two types. One is a Wenckebach AV block. The other one is a Mobitz type 2 AV block. So this is a very important demarcating line because up to first degree AV block and Mobitz type 1 second degree AV block, you may see in the ICU, it is not going to be very, dangerous. But when you see a Mobitz type 2 AV block, it has the potential to degenerate into a complete heart block or a high grade AV block and produce brady arrest. So how to identify? First you see group beating, then the clue is in the PR interval. So first PR is short, next is long, longer, this is very long, and here there is a dropped P wave. So progressive increase in PR interval with a dropped P wave is Mobitz type 1 AV block, which you need not be very much worried about because degeneration into high grade AV blocks is rare in this scenario. Or if you want to see, yes, in a simple term, what you can see is, you can see the first conducted beat and the last conducted beat of the previous Wenckebach cycle. So the last conducted beat will have the longest PR interval and the first conducted beat will have the shortest PR interval. In between will be the non-conducted P wave. So when you see this pattern, group beating, then you have to diagnose Wenckebach AV block. Whereas, and the QRS will be relatively narrow. Whereas in Mobitz type 2, there will be a fixed PR interval. Suddenly the P wave will get dropped in between. So this is a Mobitz type 2 AV block, which in the ICU you have to remember has the potential to degenerate into a complete heart block or a high grade AV block. And the QRS is generally wide. Simply, this is a suprahisian AV block. This is an infrahisian AV block that has a more sinister implications. Next one is complete heart block. So complete heart block, there is a P waves, QRS complexes, both are regular, but there is no relationship between the P wave and the QRS complexes. The one thing you have to be very carefully aware of in patients with complete heart block is the escape rhythm, the nature of the QRS complex, how fast it is and how wide it is. The faster, the narrower the QRS complex in complete heart block, the escape rhythm is relatively stable. You may have some time to act. Whereas if there is a broad QRS complex, pulse rate is quite low, around 20-25. It is either a myocardial or a bundle branch escape, which can be very unstable and suddenly can degenerate into asystole. So this you have to be very careful. The second one is such an example. The first one is a narrow QRS, relatively faster escape, that is more in the junctional area. So the QRS is narrow, rate is around 40 to 45. Other one is high grade AV block. This again is very, very slippery diagnosis here. So when you see it normally, what will be there is the patient will have a PQRS. The pulse will be totally normal. But suddenly, for a few seconds, none of the P waves are getting conducted. This is not complete heart block. This is more dangerous than that. So there is conduction, but paroxysmally, intermittently, there is a total loss of conduction, and there is no escape rhythm in the ventricle also. So this can suddenly present as a cardiac arrest or syncope. So when you are not alert, but like nowadays you have this continuous monitoring, but otherwise if you are not able to see that, suddenly the patient will have a fits or syncope or an SA attack. But if you see after a few seconds, the patient will have a normal rhythm even in the monitor or in the pulse rate. So this again is a similar example. So normal conduction, suddenly what happens here is there is a atrial tachycardia. So in an already stressed AV conduction, whenever there is a small atrial tachycardia, the conduction totally stops here and the patient has a total asystole because of the atrium is still having tachycardia, but there is no AV conduction. And slowly this goes on like that, and there is a Brady-induced torsades. Brady-induced torsades de pointes, and this is a precursor of cardiac arrest. So in the ICU, if you see such things, then this is a precursor of cardiac arrest. How will you treat this? Cardiovert this? Or the best thing to do will be to put in a pacemaker so that the sudden paroxysmal AV blocks do not occur and the patient will be saved from a cardiac arrest. So coming to tachyarrhythmias. So coming to the ICU identification and treatment of tachyarrhythmias, like I told you, so basically we have to find out whether it is a hemodynamically unstable or hemodynamically stable arrhythmia. In stable arrhythmia, you should decide whether it has the potential to degenerate into an unstable arrhythmia, and you have to make a quick diagnosis. And if you are not able to make an accurate diagnosis, you should have an algorithm or you should have a treatment plan that will effectively terminate the arrhythmia and retain hemodynamic stability. So if it is hemodynamically unstable, don't break your head, don't go to the ECG books. So possible a trial of IV antiarrhythmic agent and cardioversion or defibrillation if you are not very sure of the mechanism of arrhythmia. Most of the times, 90% it will work. In what arrhythmias it will work? It will work in re-entrant arrhythmias, whereas automatic tachycardias will not respond to cardioversion. So give 1 or 2 shocks at maximum intensity, meaning 200 joules with biphasic, and then if it does not revert, then start on antiarrhythmic drugs. So like I told you, this is a wide QRS complex tachycardia. This is the, the nightmare of all tachycardias. So it could be SVT with aberrancy or VT. So either it could be of ventricular origin. So generally, the general dictum is, if in more than 80% of patients, a wide QRS tachycardia is a ventricular tachycardia. In a patient with previous history of myocardial infarction, 97% wide QRS tachycardia is a ventricular tachycardia. So if you see a wide QRS tachycardia and treat it as VT, you will be almost always correct. And you will be only, and even a SVT with aberrancy, you will only be over-treating. You will not be under-treating the tachycardia. Trying adenosine first to 6 milligram, 12 milligram, diltiazem again 10 milligram, 15 milligrams. In a patient with wide QRS tachycardia is going to be detrimental, especially when the patient is hemodynamically unstable. Please cardiovert. Then we will think of the mechanism of arrhythmia, do a bedside echo, see if there is any scar, if it is a normal ventricle, whether there are Q waves in the ECG, whether he has undergone a past bypass surgery, all these things you can think later. But one thing that will help you is, you ask the attender or patient whether he has had a heart attack in the past. If yes, it is a wide QRS complex tachycardia is a ventricular tachycardia. Your algorithm ends there. There is only one question you are going to ask. And then if you, depending on the response, you can decide whether it is a SVT or VT. You will be 97% correct. And not a left rabbit ear, right rabbit ear, morphology, precordial concordance, and all these things, the width of the QRS complex, the Brugada's algorithm will not help you in this situation. The most common error consists of misdiagnosis of SVT with functional bundle branch block with ventricular tachycardia is the correct finding. So always think that maybe it is SVT with aberrancy, first adenosine kurtu papom. Not like that. If it is unstable, BP is low, please go ahead and cardiovert. The other misconception is hemodynamic stability. Hemodynamic stability is a myth, meaning the patient can be hemodynamically stable at one point. Within 5 minutes, he can rapidly degenerate into hemodynamic instability. He may go into pulmonary edema, he may go into hypotension, or the tachyarrhythmia itself may degenerate into a VT stable VT can degenerate into VF or polymorphic VT. So, cardioversion, everybody should be aware of cardioversion. So, indications for cardioversion is VF, VT, SVT, and if there is increased automaticity, this will not work, like an ectopic atrial tachycardia. So, it will not work. But for all other VTs, this is going to be very useful. So, polymorphic VT and the torsades. Torsades is a setting of congenital or acquired prolonged QT interval. So, there is a So, this is torsades. So, this is twisting around the points. So, if you see one lead, there is a ECG where it is very small complexes, slowly it will become bigger, then small complexes, then it will become bigger. So, this is a typical torsades D pointus. So, this occurs before the cardiac arrest, and when you see this type of arrhythmias, this is going to be lethal. This is a polymorphic VT if the baseline QT interval is normal, and it is named as a torsades de pointus if the baseline QT interval is prolonged, but both of them will have the same morphology, and this arrhythmia is responsible for more than 50% of cardiac deaths in the world. So, before death, this is the pre-terminal arrhythmia. Most of the deaths occur because of this arrhythmia. So, this again is a torsades de pointus. So, the main thing is to cardiovert the patient and then see whether there is a baseline QT is normal or prolonged. Whether baseline the patient has ischemia or there is a non-ischemic pathology. If there is QT prolongation, then you have to treat the QT prolongation. If there is bradycardia, the patient may require bracing or isoprendlin, or if it is ischemia induced, he needs immediate relief of the ischemia by either by drugs or by intervention. So, this again is a small case study. A female presenting with severe LV dysfunction. So, presenting with atrial fibrillation. So, she was started on amiodarone and put on a Holter. So, the patient had monomorphic VT. So, this is a typical monomorphic VT. Then she was put on amiodarone, and then this started to become a polymorphic VT or a torsades de pointus, short bursts of VT, and when you see here there is a QT prolongation. So, this is a typical indication, typical drug-induced QT prolongation because of amiodarone. And this again is a 74-year-old male with calcific AS, and recurrent syncope. So, what you see here is the patient has recurrent high-grade AV blocks. So, other things that you may find in the ICU that may mimic a myocardial infarction is, one is ST elevation because of early repolarization. So, what you will see here is there will be a prominent J point elevation in these leads, but it will be a concave upwards ST elevation. The patient will be totally asymptomatic in the cardiac point of view. You should not mistake this as a acute coronary syndrome. So, again this is a prominent J point elevation which is because of early repolarization pattern, and this ST elevation can also be seen in Brugada syndrome, in ischemia and early repolarization and short QT syndromes. There are other causes of ST elevation you have to be aware of. Then coming to hyperkalemia, one thing that you can find out by an ECG without looking at the electrolyte reports is hyperkalemia, which is very dangerous if not treated and identified promptly. So, this is the tall peaked P waves that we see in hyperkalemia, and the other thing that you see is flattening of the P waves, tall T waves widening of the RR interval, and widening of the QRS complex. This is a hyperkalemia ECG. Coming to pericarditis, again another cause of ST elevation, but it will be a concave upward ST elevation will be pericarditis. Again, this is also a pericarditis, and one thing that will be prominent is the ST depression that you see in AVR in pericarditis. Then coming to Brugada's syndrome, a huge ST elevation like pattern in V1 and V2 will identify Brugada's syndrome, but not a typical RBBB. Then the last one is HCM. Hypertrophic cardiomyopathy can present to you like a severe ischemic pattern, but the patient will not be symptomatic in the cardiac point of view. And if you see such an ECG, huge QRS complex with ST depression and deep T wave inversions, always do an echo and rule out hypertrophic cardiomyopathy. And these things can mislead you in the ICU. So again, in the ICU, what you see here is roller coaster T waves. So where will this be seen? In subarachnoid hemorrhage. Subarachnoid hemorrhage or cerebral pathologist, patient presenting with altered sensorium. When you see this, please do not diagnose as a cardiac ischemia and give heparin. It will be catastrophic because the patient may have a subarachnoid hemorrhage. This is a typical roller coaster T waves of subarachnoid hemorrhage. Drug effect, I think we will stop with that because of want of time. Thank you.
That was really wonderful and interesting presentation, sir. Thank you very much. And I also thank our esteemed chairpersons for leading this session. Now I cordially invite Dr. Adil Vendan sir, senior anesthesiologist, to give felicitation and mementos to our admirable chairpersons and speakers. Thank you, everyone.